All right, guys, we'll get started. I'd like to thank the Alabama Fire College for hosting us today and sponsoring us now. We're down in Tuscaloosa. We're going to do lectures from 9 to 11 today. It's not too late. If you want to come out from 1 to 3 o'clock, we're doing skill stations. We're going to be doing airway management. We're going to do some mega codes, some scenario-based training with myself and Chief Ward, and then we're going to be doing some pit crew CPR. So from 1 to 3, we're here. And it's not too late to get here for this morning's 10 o'clock lecture as well, so don't be shy. All right. I guess we'll get started. Chief Ward, anything from you? Take that as a no. Good. All right. Very good. All right. All right. So EMS Challenge started about 5 years ago with a goal to increase Con Ed in the greater Birmingham region. We are now switching that out to make this the BRIMS region, and then beyond with the state through the Alabama Fire College. So what we're going to be doing, and then starting in the upcoming future is taking 1 class per month, going out to the regions and doing the online education with in-person as well, and then doing skills training those afternoons. So updates for the day. Remember, protocols did come out in June. There are a lot of new things out there as far as especially EMTs using blind insertion devices and capnography. These things got to be trained on, guys. You cannot go out and just practice these on mannequins and expect to be competent in the field. So please get with your training officer or your medical director to work with these things. If you need help finding a medical director, reach out to me. I'll be happy to help you find somebody that's active in emergency medicine right now. All our classes are now on the YouTube at the Alabama EMS YouTube page. There's a way to get Con Ed for that. Remember, National Registry has waived requirements, so you can get all your Con Ed for this renewal cycle online, so you can use that as well. COVID is still here, even though admission numbers are going down statewide. COVID is still here. Fall season is upon us. Flu season is coming up pretty soon, so be careful, guys. Make sure you're still wearing the appropriate PPE. And remember, if you're ill, check into your human resources or your EMS officer. System entry for the state at TCC. Remember, if you're going to enter somebody in the trauma system, enter them early on while you're on scene to get assistance into where you need to go. There's been limited downtime with the trauma system in the state, but still, early system entry for stroke, trauma, and then STEMI is in the BRIMS region. That is going statewide sometime in the next year, so get ready for that. There's some updates at the federal level as well. I wanted to mention at the DEA, there's a Protecting Patient Access to Emergency Medicine Act of 2017. I just heard some feedback. That's actually in the public notice part of this. We have until December 5th to make public comments on it. The short version of this is basically what it's saying. This is going to change some of the rules that we have to use to get controlled substances for EMS. So in the past, you have to have a physician that has a separate DEA license for each agency they work for. This is going to make it where the agencies themselves can apply for a DEA license and be able to dispense and provide controlled substances. There are a few other things as far as regulations on how to keep up with those, how to keep up with the waste, how you order. So it's a really big move forward. It's going to take you away from having to have a physician with a separate DEA number for your agency. So you can go to the DEA webpage, look this up. We have until December 5th to put comments on it, and then hopefully go into law within the next couple of years. I'll have to change from here. I can't get the clicker to go. So ketamine came out again last June or June before that, doing much better that I see from the ERs. But remember, ketamine is a great drug for agitated delirium, excited delirium. It's also a decent drug for pain control. But once you give a patient ketamine, they're now critical. It is not that psych patient that just needs evaluation. One that gets ketamine for any reason, whether it be excited delirium or, quote, low dose for pain control, once you administer that medication, they now need to be exposed. You look for life threats, for holes in them, patches, things that can make them all confused. They get on a sat monitor at least, okay? If you have Untitled capnography, they get that. If they become hypoxic, they do not get oxygen, okay? They get airway management. Ketamine does not cause hypoxia. It causes decreased respirations, which then leads to hypoxia. So post-ketamine, you adjust the airway, nasal trumpet, jaw thrust. If that fixes them, you high-five your partner, you call it a good day. If that doesn't fix it, then you reach for the O2 and the BVM and you ventilate them. You cannot just apply oxygen. Remember, a lot of agencies now are using passive oxygenation for rapid sequence intubation or even for CPR. So we know that oxygen in an apneic patient will keep their sat up for 6 to 8 minutes. Very bad for the patient. So hypoxia post-ketamine is treated with airway management, nasal trumpet, jaw thrust. If that doesn't work, OPA, iGel, BVM. If that doesn't work, they get intubated. Upcoming Con Ed, remember the EMS conference is coming out next week, I do believe. It's virtual. It's going to be Wednesday and Thursday. There's an in-person tactical medic class and also critical care paramedic class. I'm not sure if there are any spots left for that. You can reach out to EMS conference and ask them. But good Con Ed, low cost, high quality, and again, you can get all your Con Ed for this cycle online. November 11th, we'll be back at Centerpoint Fire Department. On the 18th, we're going to be at Pelham Fire Department. In December, we'll be in Anniston. Chief, if any of this is wrong, let me know. And then January, we'll be out at Foley doing EMS Challenge. Okay. Oh, my bad. So November 18th, we'll actually be at Shelby Baptist with Alabaster, not Pelham. So I just kicked somebody with that, I think. So good job, Dr. Ferguson. Great. In December, we'll be in Anniston, and January, we'll be out at Foley. Unless I mess it up again. So first case for the day. I'm going to try to steer away from some EKGs. We're on the road. Keep those at Centerpoint. So first case, you got a 38-year-old male dispatched for an allergic reaction. Supposedly he was working in the yard, dug up a yellow jacket nest. He has multiple stings, complaints of rash and pain to where he's been stung. So what do you do? What are our thoughts for this guy? Anybody know? Anybody care? Nobody's going to make eye contact. We have a small group here. Great. Thank you very much. Feel like I'm at my house with my kids. This is good. So obviously, you know, we teach the medics in, you know, scene safety. All right. So things you want to do is make sure that the wasps are gone or yellow jackets are out of the way, move the patient out of that area. And then we're going to do basic stuff. We're going to look for, get a history and physical and do a basic exam. Okay. When you think about allergic reactions as a spectrum, it's sort of like ACS or anything else we learn about. So you got to determine what's going on with this person. Is this really allergies? Is it an allergic reaction? Or is it an in-case spectrum of anaphylaxis? When you think about allergies, all these things work together. So basically what happens is the body gets exposed to some kind of foreign product, some kind of foreign protein. Those things make antibodies. These antibodies then kind of circulate in the body. So now they're exposed to that protein, the body can attack it. The problem is some people have a hyper or exaggerated response to this response. So for example, if I get stung by a bee this week, I probably won't have an anaphylaxis reaction. I don't have any antibodies against them, right? But 6 weeks from now, my body has these antibodies. Some people are unlucky and make a lot of these antibodies. So next time I'm stung, these antibodies reach out, touch allergen or protein, and attack to this mast cell. And they do it exaggerated. When they touch this mast cell, it opens up and releases histamine and a lot of other proteins and enzymes. Histamine is a problem. Histamine causes all kinds of problems. Now, some people with allergies, like in the fall, when the leaves start falling, people get an allergic reaction, you get a runny nose, you get eyes get watering. Not a big deal. You get a mast cell response, but it's not really massive, not super scary. A little bit of histamine comes out, body does good with it. Other folks, for example, somebody who has a seafood allergy may go out and have seafood, a papados down in Birmingham, have an allergic reaction. They have more antibodies, a little bit exaggerated, more histamine is released. They get more of a reaction. They get a rash, they get itching, they have problems. And it's a minor to moderate reaction. Usually you have 1 or 2 organ systems involved, so they have a rash and they itch. Maybe they have a rash and a small wheeze. But more than 2 organ systems, we get pretty concerned about anaphylaxis. And that's someone who's having an exaggerated response to these proteins. And what happens here is you have multiple receptors attaching to this mast cell, multiple release of histamine, and now you got more than 1 organ system. Now you got the guy that's got a rash, they have whelps, they have wheezing, they have angioedema, and that's anaphylaxis, and that can be life-threatening. So one of the first things you got to do when you don't see is determine what's going on. Is this a minor reaction? Is it a moderate? Or is it pretty severe? Because folks with true anaphylaxis can die on you pretty quick. and you got to be very aggressive in your care of those people. So the body's response to histamine. When this histamine is released, a lot of things happen. So obviously, you're going to get an increase in heart rate. Histamine causes vasodilatation of all the vessels locally around where the insect bites you, or if it's something you ingest, it's in the GI tract. So you get vasodilatation, you get hypotension, which causes increased heart rate, tachycardia. You get effects that cause bronchial constriction as well. So now you got somebody who's hypotensive, and now they get spasms and wheezing, and they get hypoxic. All right? You also get, because of the same response to the vessels where they dilate, same thing happens to the skin. So you get whelps, and they get fluid loss, third spacing of fluids, and they get more hypotensive with that. You have people who get nausea, vomiting. Sometimes the edema in the gut causes diarrhea. So a lot of problems with this, with histamine. And this is just one of the receptors, or one of the chemicals that's released. The other cytokines and enzymes that cause similar problems as well. So again, this is a spectrum, right? So you can have anything from mild allergies, runny nose, eyes watering, to a rash, to anaphylaxis, which is very concerning. So this is just a quick video of whelps. You can see how the skin goes from the blanching to third spacing of fluids. So a lot of stuff going on there, a lot of change in the skin tissue. And again, the way this works is you've got an allergen or antigen attaching to an antibody. Okay, first contact, the next contact of that protein. We good? Yeah, I couldn't get the clicker to work, yeah. So, so antibodies, they attach this mast cell, which is a massive cell. It's really big. You got mast cells and you got basophils, and that's getting kind of high tech. Mast cells are living in the subcutaneous tissue, they live in soft tissues, they live outside the vessels, and then the basophils actually circulate around. Those things are ginormous. So when these proteins attack to this, it just spills out all of that histamine, causes all kind of issues. And you can see how we got third spacing of fluids here. So I would call this a moderate reaction. This is somebody who has significant skin changes, all right? Maybe not anaphylaxis if there's no respiratory component, no GI component, there's no stridor, but definitely concerning that needs urgent evaluation and probably treatment as well. Then, when you think about anaphylaxis, this is the scary stuff. This is somebody who's been pre-exposed to some kind of allergen. And the next exposure, the body just goes crazy. The basophils, the mast cells explode, releasing histamine. So you get massive hypotension, massive third spacing. You get bronchial dilatation. The other problem is you get a lot of soft tissue swelling in the oropharynx, in the neck, and the throat. Very bad for airway compromise. Okay, you see a rash, that may be wheezing. Talks about CNS issues. Basically, that's due to the hypotension. They may get confused. They may have syncope. A lot of problems with this. And the problem is that the body can't respond without our help for the most part. So these folks can go into cardiac arrest in a short amount of time. So urgent treatment has got to be made. But to treat them, you got to be able to recognize what's going on. All right. So back to our first guy. He's a 38-year-old fella, stung by a bunch of yellow jackets, pretty aggressive, on scene. BLS is the first guys on there. Obviously, we're going to do scene safety, getting back away so he's not stung anymore, all right? And then, anybody ever been stung by yellow jackets, ever been attacked by them? Those things are mean, right? So I've been attacked, and you look down all over your clothes, your jeans, your shirt, they would kind of latch on to you. So this guy would probably get him out of the area, get him in the back of the rescue on the other side of the truck, get his clothes off, expose him, do a quick exam, and see what's going on, all right? So this guy's got whelps. He's got those, like we saw, the urticaria, all right? Respirators are 28. Now, people get really excited about respiratory rate counting, okay? Work of breathing is more important than rate, all right? So if I'm looking at this guy and I'm going to count for 15 seconds and I get to 6 before 15 seconds, I know he's breathing over 24 times a minute. I don't care at that point in the game. It doesn't matter. I'm not going to watch my watch for a minute and say he's breathing 42 times a minute, because if he's breathing more than 20 times a minute with whelps and a rash post-insect or bee stings, he's pretty sick, all right? Heart rate is tachy. You reach down, you feel his pulse. He's got a radial pulse that's weak, but it's there, pretty thready. Your partner throws a stat probe on it. He's sat 90%. Quick blood pressure shows he's 100 over 60. For Alabama, this is hypotension, right? Nobody in Birmingham or greater Birmingham area has a good blood pressure, right? All right. So sick or not sick, I would say he is sick. Sick as dirt. Got a BLS truck on scene. Things they can do, right? So we talk about EMTs. EMTs have a humongous scope of practice these days. I mean, this is a lot of what paramedics did initially when paramedicine started in the late 70s. So EMTs should better recognize the guy is sick, recognize what's going on, recognize his anaphylaxis, okay? Things that we can do is we can apply supplemental oxygen. He gets a non-rebreather on if you got it. If not, throw a nasal cannula, crank it up to 6 to 8 liters. That works pretty good as well. I'd be prepared to help manage the airways. Think about having your embu bag out there. And then things I'm going to ask the guys like, hey, man, you got an EpiPen? Anybody who got an EpiPen? State says you can help them do that, right? Epi is the drug of choice for anaphylaxis. Grab that. The guy's exposed. He's got one. Help him, okay? Give that to himself, either in his thigh or his deltoid. Works pretty good. The next thing I'll be thinking about is, does he need to be transported by BLS, or am I going to wait for ALS? It depends on the time factor with that. Because what he really needs is what? Epinephrine, right? So if he doesn't have an EpiPen, we've got to get ALS there to get that drug there. So on the radio, calling for ALS support. ALS can do a lot more. Is the paramedics. Things we can do is epinephrine, obviously very important, probably the most important thing. We have other drugs in our toolbox. We got albuterol, we got Benadryl, we got fluids we can give. State also recently changed and allowing us to push dose epi. We'll talk a little bit about that this time as well. There's a time and place for push dose. All right. So ALS arrives on scene. Now the patient is more altered. Respiration is now 14 and labored. Does that mean he's getting better or getting worse? He's getting worse, right? So now the dude's wearing out. He's got stridor. He's also got audible wheezing as well. So you think about the mechanism for the wheezing is obvious, is bronchoconstriction, right? So he wheezes like we hear from an asthma or a COPD patient. But the stridor is super concerning. That means that the vessels in his throat and his mouth are leaking out fluids and swelling, and we got big angioedema, okay? So that means, one, it's going to be hard to intubate them if we have to intubate them, all right? And two, if you can't intubate them, you got to think about a surgical airway, it's just as bad because of all the edema as well. So we got to reverse this pretty quick, okay? Guy's got marked urticaria, replete vital signs, heart rate is now 148, blood pressure is 60/40, so really sick, he's anaphylaxis. So what's the first thing you would do for this guy if you're the medic that showed up on scene? Right, how do you give the epi? IM. So we used to talk about giving epi sub-Q. You don't want to give it sub-Q. When you get hypotensive, all the vessels going to the skin constrict down. It's not going to do any good. Can you give it IV? Potentially yes, but that takes a few minutes to get IV access on somebody. So epi IM is the way to go. You want to give the 1 to 1,000, okay? Technically, you give 0.3 milligrams, so you break up from the vial, draw out 0.3 and give that to them. In reality, if you gave 0.5, that is fine, okay? How many vials of 1 to 1,000 normally y'all carry in the truck? 3, 4? What do y'all carry at Center Point?
So we carry 2, 1 to 1,000.
Okay.
Right now, since we still refills ranges, we got an additional 6, 1 to 1,000 stations range.
So you have plenty of the 1 to 1,000. So for those y'all couldn't hear that, he says they normally carry 2, but now they get up to 6 because the shortage of the 1 to 10,000. I know I've worked some places where you only had 1 of the 1 to 1,000. If you got that, you don't want to waste it. I would draw it all up. You give 0.3 or 0.5 in your first stick, wait, and then you got another dose if you need to as well. Epi is what saves these people, most important drug. Obviously, they need oxygen. We're going to need IV access. We need to do other things. But Epi IM is what you're going to do for this guy. It's quick and it's easy, all right? You can also do some albuterol and racemic epi, all right? So if I'm giving the IM epi, I'm going to have my partner mixing up some albuterol. The albuterol is going to help with the upper airway of the lungs. Racemic epinephrine, some people carry that. It's a little bit of a cost. You can actually make your own racemic epi and held epinephrine out of that 1 to 1,000. If I only had 1 vial of 1 to 1,000 and the guy with anaphylaxis, I would not waste any for racemic epi. I'd probably draw up half of that vial, give it IM, wait a few minutes, 3 to 5 minutes. If he's getting better, I high-five my partner. We smoke a cigarette. It's a great day. If he doesn't get better, he gets the other epi IM. But if you have racemic epi or have extra, you can go ahead and give racemic epi. It's going to dry up the secretions in the upper airway, help vasoconstrict those vessels, and help with that stridor. Can you mix the two? Sure. You can mix albuterol, your dual neb, and racemic epi, a couple of cc's of saline, and nebulize that. Works well. Limited risk, but potential benefit. Guys also can get IV access. I'm going to initiate IV fluid bolus to help increase blood pressure. But when I give the IM epi, that's going to do the best bet because it's going to stimulate both beta and alpha receptors. Benadryl is another drug we can give. Benadryl is great. It's an antihistamine, and that's what's causing a lot of these problems. So Benadryl IV is very reasonable. If I could not get IV access on this guy and I'm given 1 or 2 doses of IM epi, I would call med control, get orders to give Benadryl. Works relatively quick. And then I'm going to reassess. So this patient is going to be epi, reassess, as I'm working on my nebs, IV access, IV fluids. Okay? Questions, comments, statements within reason?
I've got one question online.
So the question was, is there a difference in allergic reaction between wasps and honeybees? I am not Dr. Rushton. I'm not a toxicologist, so I don't know all the details. But you can have an allergic reaction from any foreign protein. Yellow jackets are more aggressive. They cause problems. But people can have anaphylaxis from ant bites as well. So it depends on the person is the appropriate answer for that question. Okay, so the question is intubation versus epinephrine for severe stridor. I would do epinephrine because if you try to intubate someone, you're going to have massive airway edema if they already have stridor and they're going down. So IM epi is probably going to buy you time. So I would do IM epi. I would do high flow, 6 to 8 liters nasal cannula, and then you can assist ventilation with the BVM if you need to. But IM epi is the drug of choice. So I would hold everything off till you get that going. That's paramount to save these people. You're seeing 2 different things, correct. You're seeing vasodilatation, so the vessels get big, and then because the basophils are hanging out and they release that histamine, it's going to make that cell wall of the vessel open up so you get third spacing of fluid, so they get hypotension from that too. Yes, the short answer to that, yes. So epinephrine will cause vasoconstriction, and the constriction itself is going to make those vessels the less permeable as well. Yeah. All right, so if you go back to our protocols, it talks about use of epinephrine. There's some warnings here, many adverse reactions, including hypertension, tachycardia, dysrhythmias, tremors, anxiety. That's why we only use epinephrine on people who have anaphylaxis. So if you have somebody who's found their neighbor's pet and they call you and now they're itching, they got a sniffle and a runny nose, that's anaphylaxis, right? Issues there. Someone who is already hypotensive, even though they're tachycardic, they need epinephrine. Protocols also talk about rapid transport for these people, and that is situation dependent. If you have access to epinephrine and fluid and resuscitation equipment, if you're an ALS provider, you don't need to transport this patient until you stabilize them, all right? I'm going to give them epi, I'm going to give fluids, I'm starting with I've got IV access, I'm hitting them with fluids, I do Benadryl. When that's done, it's probably been 6 to 8. They're not improving, they get 1 more epi, and at that point, I'm probably going to pick them up and head to the hospital. What I'm not going to do is show up as an ALS provider on scene, anaphylaxis, I'm going to throw him in the back of the truck and head to the hospital and then start care. He needs immediate treatment right there on scene. Now, anybody that goes into anaphylaxis that gets epinephrine needs to go to the hospital. You can get a rebound effect, and that epi wears off, they can go back into anaphylaxis, all right? Especially somebody who's got multiple bee stings, or especially if it's an ingestion of food or something like that. So then you go to the hospital, but we manage these people on scene, we stay in place, so to speak, and stabilize them. Other things we do once they get to the hospital, we add steroids. Steroids are anti-inflammatory. These take about 4 to 6 hours to kick in, so they last up to 8 to 24 hours. So we give them steroids. We also give them other blockers. So Benadryl is an H1 blocker, histamine blocker. We give them H2 blockers such as Pepcid or Zantac. Give that IV. There's some cross-reactivity, works pretty good, and we watch for rebound. Now, a few weeks ago, the state came out talking about push dose epinephrine. So it's a 1 to 100,000 concentration. That's something we did not talk about in basic paramedic education. But this is basically the same concentration you do if you do an IV infusion. But we're saying now that you don't have to mix an infusion, you can do baby doses, push doses of epinephrine. This would be a really good place to use this. So you know they need epinephrine for anaphylaxis. If you have IV access, this is a reasonable place. Hypotensive, anaphylaxis, push dose epi. The caveat to this is you got to be very careful. If you give somebody a big dose of 1 to 10,000 epi, you can put them into VTAC or VFib. Poor form. It's pretty cool. You get to defibrillate them, but it's poor form, right? So you got to make sure that you mix this correctly. So a couple of ways to do it. If you have pre-filled saline syringes, you squirt out 1 cc of that, so you got 9 mils of saline in your syringe, all right? Hook a needle up to it, and you draw 1 cc out of the 1 to 10,000. That way you can't draw any more. There's no way to get too much in there. And then you're using 0.5 to 2 cc's of epi IV every 5 to 10 minutes and looking for a response. The other way to do it is you put 10 mils of 1 to 10,000 in a 100 cc bag, and you got that pre-mix, and you draw up your fluid that way. I prefer the syringe method, but again, before you start using push dose epi, you need to do a couple things. 1, talk to your medical director, make sure they're okay with this. 2, have training, practice. You do not want to be in the heat of the battle and drop the wrong dose of epi and take somebody from anaphylaxis to VFib. Very poor form. I have seen several patients in my career who have given epi for bradycardia or allergic reactions, and it did not turn out well. So you do not want to make that mistake. Our job is to help people, not hurt them. One of the rules we talk about when I talk to the residents is you don't want to kill people, right? You want to try to help people if you can, and you want to go home with a clear conscience. And if you're pushing 1 to 10,000 epi IV on somebody with a pulse, you're going to break all 3 of those rules. Questions, comments, statements within reason. All right. Next case, 23-year-old female, history of asthma, dispatched for shortness of breath. She's had 1 day of shortness of breath, no relief with home medications or her menthol cigarettes, because you know that actually works in the Deep South. Menthol cigarettes are great, right? That was a joke, yeah. All right, so BLS arrives on scene. What are they going to do? We've talked about it. EMTs have a big scope of practice. A lot of places are going break to first BLS response only, and then calling for ALS if they need it. So patient assessment, what's going on with the patient? Are they sick or not sick? All right. So this patient has a heart rate of 130, blood pressure is in the 120s over 70, breathing 34 times a minute. I've already kind of talked about the work of breathing is more concerning than rate. And it's somebody, if I get to like 4 or 5 breaths and under that 15 seconds, I'm super concerned for them. Stats are 86%, also very concerning. So we're tachycardic, hypoxic, tachypnic, concerning. On physical exam, she's alert, but she's anxious, moderate accessory muscle use. She's got decreased breath sounds throughout with a little bit of a wheeze, okay? Pertinent questions you want to ask people about their history with asthma as you're doing your exam is, have you ever been admitted to the hospital for asthma? If they say yes, I got to say this correct, you know they have more serious disease. So a lot of people out there have exercise-induced asthma. They have allergy-induced asthma, bronchospasms, okay? We can manage those. Folks who have been admitted to the hospital for asthma have a high risk for decompensation. We know they have bad disease. Nobody gets to the hospital these days, gets admitted, unless they're super sick. So questions you want to ask, ever been admitted to the hospital for asthma? If they say yes, your radar should go off. We have now just screened them. They're high risk for decompensation. We should be pretty aggressive in our care. Next question, ever been intubated for your asthma? If you've ever been intubated for asthma or COPD, the risk of being intubated is like tenfold than the general population. So if you've been intubated once for asthma, you'll be intubated again at some point in your life before you die. Super high risk. Now, a lot of times I say, you ever been put on the ventilator? And they say, yeah, I use that ventilator all the time, 4 or 5 times a day. So sometimes you got to put it pretty crude. Have you ever been in the hospital? Yes. Have you ever been put in intensive care? They say, yes. Have you ever had a tube shoved down your throat to breathe for you? Make it simple, because other folks will say yes, talking about the NEB treatments. But either way, admissions, ICU admissions, intubations, super concerning. for bad outcomes with asthma. But BLS is on scene. They can recognize they're sick. They're going to sit them upright. They're going to administer high-flow oxygen. They're going to be calling for ALS. If ALS is too far out, they can start moving toward the hospital at that point in the game. They're going to ask the patient, do you have an MDI, a puffer we can use? They can help with that puffer. If they have a nebula, hook that. That's reasonable too. It's her machine. She can use it. You can assist with that. So plug it up, put a couple of doses of albuterol or Duaneb in there, take the machine with you, plug it in the back of the truck. That'll run that neb treatment while you're heading toward ALS care, okay? Now, people get concerned about the dosing of this albuterol or ipratropium bromide or Activent that they use at home. You're not going to overdose somebody on that stuff. So if somebody's an extremis, hypoxic, tachycardic with asthma, and they have their home medicines, use medicines. Even if they said, I took one an hour ago, does not matter. In the hospital, I'll give people back-to-back albuterol, okay, if they have bad asthma attack or status asthmaticus. All right. The risk of albuterol are twofold. What two things bad can happen with albuterol? Anybody know? Yeah, so you can get, if you're tachycardic and you're old, you can have a problem with that. This chick is young, probably not a problem. Most that are older don't have asthma. You don't see bad asthmatics making it to 70 or 80 years old, right? They're probably COPD. But you can't have heart problems if they get super tachycardic. And then what's the other problem with albuterol? Anybody know? So, yes, perfect. Hypokalemia. Yeah. So if you got somebody who's already dehydrated or something, and you give them back-to-back albuterol for an hour or so, you're going to drop their potassium way low. You can have dysrhythmias as well. So something to think about. Most young people, people with normal kidneys, do fine with it. But if you got a dialysis patient or an older person, that's a risk. Something to think about. Cool. Good job. Somebody answered a question. I'm excited. I feel like I'm a winner today. So obviously, what's going on with this patient? She has asthma, especially a chronic inflammatory disorder that jacks up the air sac, up both oxygenation and ventilation. So when you think about the way this works, you have the trachea, then you have the lungs, you got the lobes of the lungs, right? And then you break it all the way down to the air sacs, the alveoli, alveolar ducts. With asthma, all these areas get swollen, congested. Then you think about we can't get oxygenation or perfusion. All right. Around all these little air sacs is a blood vessel where O2 goes in when they breathe in and the CO2 comes out. If these vessels are constricted, congested, full of stuff, you get poor diffusion. So they get hypoxic. They also retain CO2, which is bad. So you have normal airway anatomy. Then you have the abnormal airway anatomy. So normal with asthmatics, even on a good day, they have thicker muscles because they've had off and on constriction. Sometimes, sort of like COPD, they get extra secretions in here, so that jacks up the perfusion they get. When they have a bronchospasm, this gets really tight. When we give the beta agonist, the albuterol and so forth, they dilate, they get better gas exchange, but they still don't get perfect gas exchange because of underlying health problems. Any questions or comments? All right, so what's going on with this patient? Obviously, she's having an asthma attack. We got problems with oxygenation because her SATs were low. We got problems with ventilation because she's breathing pretty fast. Red flags we talked about. She's been intubated. Been intubated before, and then has she been admitted? So history is very important. So we know that she's sick. So BLS is going to initiate care and then call for ALS. Then here's where it gets cool. So when ALS gets there, they got to do the same thing as the BLS guys did. They have to determine what's going on. Patient's breathing fast, she's hypoxic. You can't just go to the protocols and say, all right, respiratory distress, I'm going to give her albuterol, magnesium, epi, decompress her chest, put her on CPAP, give her a semic epi. You got to actually assess the patient, get a history, figure out what's going on, and this can make some people mad. You actually got to make a diagnosis on this patient, okay? You do it every day. Folks just told you couldn't do it. But you can. You got to figure out what's going on. Is it CHF? Is it COPD? Is it asthma? Is it pneumonia? Use your exam findings to figure out what's going on, and then pick the pathway that needs to be done for this patient. Correct. Correct. So the statement was difficulty recognizing differential diagnosis of shortness of breath. Old person, dyspneic, could be having an MI. Old person, dyspneic, a little bit wheezy, you give them albuterol and they're having an MI, you can make it a lot worse. So you got to look at the whole picture and figure out what's going on. Probably not the case in a 23-year-old, but a 60-year-old that's never had asthma before, that's now short of breath and wheezy. Sometimes you get pulmonary edema and it sounds like wheezes. If you just hit with albuterol, you got a big problem. So you got to be able to look at the patient, take a history, do an exam, do it all in 2 or 3 minutes, and figure out what's going on, and then make a decision on how you treat that patient. Right. Right. So for years there was a something called the cardiac wheeze. So basically, it was you would hear wheezing as somebody who was in flash pulmonary edema, because the wheezing is those smaller air sacs being constricted, and they're constricted in CHF because there's fluid in there. The air doesn't get there very well, but not a good thing. If you think about CHF, the problem is fluids in the lungs, and the heart can't pump it out. And if you increase the heart rate, the heart's going to pump less efficiently, so the fluid gets even removed slower, if that makes sense. We'll talk about CHF when I talk about some renal stuff as well. But albuterol is great for bronchospasms, so asthma, COPD, allergic reactions, but it's not good for cardiogenic pulmonary edema or other causes of shortness of breath. All right, so EMT started at O2, sat her upright, calling for assistance. ALS gets there. Now she's more somnolent. She's a little bit hypoxic. Can't get access. So things they can do. We talk about oxygen. Now, ALS is going to start in inhaled beta agonists. So they're going to give her albuterol. I know some places carry albuterol and ipratropium bromide, a duaneb. So that's fine. So the ipratropium bromide or Atrovent is kind of a anticholinergic, dries up secretions in the airway, and then it kind of opens them up. Not as effective as a beta agonist, but it still works. There's no risk factor for giving multiple doses of these. We used to say you could give one twice a day. In reality, what I do now is I give 3 doses back to back. That probably maxes out the receptors. And after that, you can repeat it in about an hour. There's no risk to the drug, but potential benefit. You do not get tachycardic from this as well. So fairly safe drug to use, even in older populations. But Atrovent, I give 3 doses. If you want to give more, it's reasonable, but you probably max out at 3 doses. Beta agonist, the Atrovent, the albuterol or Ventolin, I would just repeat that. Somebody this sick, I'm going to hit them with 3 duanebs or 3 albuterols, 1 Atrovent, run that till it's done, and when that's done, hit them with 3 more. Okay? Obviously, patient is super sick, they're somnolent, they're hypoxic. She'd already been admitted to the hospital before. We know she has high risk factors. All right? If I'm unable to get IV access on this person, things that we can do as well. This is where IM epi is also useful. We used to use terbutaline, which is a beta agonist years ago for asthma or COPD in folks less than 60 without heart disease. So IM epi works the same way it does for anaphylaxis. So pop over 0.3 to 0.5 mg of 1 to 1,000 IM epi, bronchodilates, buys you some time, okay, as you're looking for IV access for a better way to do that. Conventional therapy in the hospital, steroids, just like with the anaphylaxis, because it decreases the inflammatory response. And then a drug that we switched over a couple of years ago and made Cat B for asthma is mag sulfate. Mag sulfate's a great bronchial dilator. Anybody know the dose for it? 2 grams. So if you look in the literature, when you give magnesium, there's a risk of causing hypotension. You're supposed to give 1 gram over an hour. In reality, in a respiratory problem like this, you give 2 grams and you give it over like 10 to 20 minutes. I think our protocol says put 2 grams in 250 and run it wide open. In the ER, the nurses put 2 grams in 100 and put it on a pump to run over 20 minutes. And I smile and I go over to the pump and I take it off the pump and I open it all the way up and it runs in. Magnesium at 4 4 to 8 gram doses for like preeclampsia, you'd see some hypotension, but a 2 gram dose is not going to cause that. And I'm more concerned about this chick dying in the next few minutes from airway compromise, so magnesium is a great drug to use. All right, so patient gets to the hospital. She arrived to me. I was actually working in the Highlands. This is not her picture, by the way. I don't want to get in trouble. So, but in short, she was a bigger girl, bad asthma, been intubated a few times before. They could not get IV access on her, so she got to me. As soon as she rolled the door, I hit her with another epi-IM, 0.5 milligrams IM for bronchodilator. We're sitting her straight up, giving her neb treatments. I'm going to do CPAP or BiPAP. So BiPAP is great. BiPAP increases oxygenation, all right, and clears CO2. So I'm going to sit her upright. I'll put her in the BiPAP, hitting her with IM medications, and then I'm drilling her so I can give her magnesium, steroids, and then get ready for more aggressive airway management. All right? So after we got IV access or IO access on this girl, she got the MAG. She was not doing well, so we kind of moved on down the aggressive pathway management of acute asthma. All right? Which would be thinking about inhaled anesthetics, other medications we can do, and intubation. So conventional therapy, oxygen, albuterol, Atrovent until we run out of it, IM epi every 3 to 5 minutes. You would consider in the inpatient or critical care setting even an IV epi infusion if you needed to, if you're having difficulty with this. She's getting high-dose steroids. Remember, these take about 6 to 8 hours to work, but I want to get them on board quick, heavy. I'm going to give 2 grams of magnesium for bronchial dilatation. I'm going to give that over a couple of minutes. And then I'm going to move on down the pathway. So other things we can do in the hospital, we have Heliox. Anybody heard of Heliox? We used to use it a lot. We don't use it as much anymore. So basically, it's helium attached to oxygen, and you get it at 40% oxygen, 60% helium, or 60% helium and 40% oxygen. And the theory behind this is helium is smaller, so it can get into the air sacs and improve oxygenation. Doesn't help with CO2 exchange, but helps with oxygenation. The problem in most hospitals is it takes 30, 45 minutes to find it. And then if they're super hypoxic, sometimes 60% FiO2 doesn't fix the problem. If this isn't doing it for them, occasionally we use methylxanthines. So this was, what was the name of the drug? Anaphylaxis. So this is an older drug, used to use it in the late 90s. It's kind of gone by the wayside because it has a low therapeutic index. And by that I mean, if I give not enough amylophenol, it doesn't work. So if I have to give it and get a blood level of 2, anything less than 2 doesn't work. But if I get above a 2.5 blood level, for example, then it makes them worse. They get nauseous, they have dysrhythmias, get big issues. So it's really hard to manage this drug. So I've used it probably 2 times in the past 10 years, and it was when somebody that was intubated, and it was at the discretion of the pulmonary specialist for these people. So don't use this a lot. But if BiPAP isn't working, they're still hypoxic, still looking like dirt. If I can't use BiPAP because they're altered and vomiting, then I'm going to do intubation and put them on the vent. Now, the procedure to intubate them is easy. It's just passing the tube. The problem comes once you intubate, what do you do? Because everything's so constricted. At that point, normal thought process for airway management goes by the wayside. So asthmatics that are hypoxic and are retaining CO2, normal vent management is to increase the rate of ventilations, increase their oxygenation. With asthmatics, what we do really is we increase the oxygenation, but I slow their rate down. And sometimes I'll bag them 2 or 3 times, take them off the vent, and push the chest, let them exhale. They're really tough to ventilate. So drugs that I use to help with that, propofol, the Michael Jackson drug, right? Y'all remember that? It's a great drug for sedation. It dilates the bronchial vessels. They get better, less bronchoconstriction, works good. Inhaled anesthetics, some of the gases they use in the OR do great. The problem is that's tough to get in the ER. Sometimes the ICU can help with that, tough to manage. But the thing that's really saving lives is a kick-butt bronchodilator is ketamine. So ketamine is my rescue drug when it comes to asthma or COPD patients. Obviously, this is something you don't use on people that are not intubated because you don't want to give somebody ketamine that's not intubated and they decrease the respirations and makes them worse. So the patient for this chick, she continued to worsen even with BiPAP, the medicines. So she got intubated, put on propofol, wasn't getting better. So at that point, I'm doing doses of ketamine at the 1 to 2 mg per kilo IV dose, and this will open her up enough that you can ventilate her until the steroids kick in. So I don't want folks using ketamine for asthma in the field. It's, critical care can do that. Those folks got to be intubated when you do this, but ketamine is a great bronchial dilator. It's a good rescue drug for asthma or COPD. Questions, comments, statements?
Yeah, we've got a couple come in.
Oh, good.
So one is CPAP good for conscious and
CPAP, I would say no, because the problem with anaphylaxis patients is the hypotension from the histamine response and the airway edema. So they need epi before CPAP or BiPAP. So I would do epi on those folks and high flow O2 and not CPAP or BiPAP.
okay, so the other question deals with patients who are regular asthmatics call us to give them NED treatment, primarily because they're out of their NED treatment.
Right.
So we give them a NED treatment, and then they refuse transport. So a lot of people call technology to guide them on when to take the step three.
Okay.
So we've had a couple of instances where within that, higher stress.
Yeah. So the question or story was refusal of treatment for folks who are chronic asthmatics that call you out to get NEB treatments and therapy. Is capnography useful? I think I would use initial assessment and history for first thing that you think about. What is their work of breathing? Are they working hard? Are they hypoxic when you get there? Those are big red flags. The next thing I would do is history. Ever been admitted, ever been in the ICU or intubated? Those are red flags. Those folks should be told to go to the ER. Now, obviously, we can't force people. If they're awake and alert and they understand the story that, hey, you have bad disease, you're hypoxic, we got you better now, you could get worse, there's a chance you could die. If they understand that and don't want to go, we can't force people. But you have a serious discussion with them. Use of capnography is useful, but the problem is if you give them the treatment and they get better and they feel better, your capnography is probably going to show they're getting better anyway. So it really doesn't help you that way. So I think work of breathing, initial SpO2, are they hypoxic when you get there, and history should determine how hard you push them to go to the hospital. The other thing that would help with that is if you have an active medical director, that's somebody you can call, then you can get a community paramedicine program out there to help them, maybe refill medicines, get them tied in, so they get better continuity of care so they don't need you to come out to give a NEB treatment. But that includes having a doctor work with you and having a community paramedicine program as well. EMS, my understanding is we really can't bill for those things either, so there's a big burden on the agency that goes out there. With some of the new stuff coming out with ET3 in the next 5 to 7 years, you may be able to bill for some of that, and that may take some of that away, some of those calls.
Other comments you have about cardiac arrest, very difficult.
Yes. Right.
So taking the bag off the tube, physically switching this a couple times.
Right. Not at all. Not at all. So when you look at American Heart and you look at ACLS, these classes, I'm not dogging them. I'm just making a statement here. They dump all cardiac arrest into one big pool, and that's not the case. A 23-year-old with asthma that goes into cardiac arrest, she needs early intubation, right? There's an airway problem, needs early intubation. If you got a video scope, that's the best way to do it. She probably needs IM epi to get IV access. Then she needs IV epi in the cardiac arrest. Then she probably needs magnesium as well for bronchial dilatation, all right? And then when you ventilate her, instead of the 8 to 10, if she's hard to bag, maybe you do 3 to 4 and you help her exhale. You look at the underlying problem, what caused them to go into cardiac arrest, and you try to fix that, okay? That takes you, the paramedic, making a decision, making a diagnosis, and looking at the whole picture to do that. You can't do that on the 40-year-old STEMI cardiac arrest. That person's going to intubate, and they're going to be ventilated, 10 to 12 times a minute. It's a little bit different. It's time that we use all your skills, make the diagnosis, and do the appropriate treatment. All right, let's talk about drugs I want to talk about. Obviously, epinephrine, we talked about it. It increases cardiac output. There are some issues with it. When you think about using IM epi, it is category B for age 65 or older. I've seen a couple of folks use IM epi for COPD exacerbations in people that are 40s to 50s. I would say that's probably not the thing to do as well. If I'm 40 and I have bad COPD that makes you want to give me IM epi, I probably have heart disease as well. Probably not a good idea. I'd probably double up on the Duanebs, think about the magnesium, think about early BiPAP with that. We talked about racemic epinephrine. You can use that as well. It's a 2.25% solution, or you can make your own out of 1 to 1,000. Don't get complicated. Half a milligram of 1 to 1,000 with 3 cc's of saline works fine. If you put 0.6 milligrams in there in 3 cc's of saline, not going to make a big difference. Okay. 1 to 10,000 is IV use. It is only in cardiac arrest. If you want to use the push dose epi, it's 1 to 100,000. That means it's 1 mil and 9 mils of saline. And again, if you're going to do that, you need to talk to your medical director. You need to get with your EMS officer. You need to practice mixing this medicine up. You laugh when I say that, but I'm telling you, I've seen people mix this up inappropriately, mess it up, and people have a bad outcome. And if you're trying to make this at 2 in the morning in the heat of the battle when everybody's nervous, you're going to make a mistake. And you can't make a mistake with this drug, guys. So practice making it up. If you have a way to draw it up beforehand, label it, and use that for your shift or for your week, that's reasonable too, if you can get your med director to sign off on that. The other drug I want to talk about, diphenhydramine. What's the other name for it? Anybody know? Yeah, get it, Benadryl. I'm so proud of myself. I was at 2 o'clock in the morning doing that one. Benadryl, yay. It's a histamine blocker. It's an H1 blocker, so it's useful for anaphylaxis. We talked about in the hospital, we use H1 and H2 blockers. H2 is the Pepcid or Zantac, but Benadryl. Dose is 1 mg per kilo for kids. I do that for adults as well. So I have an adult with anaphylaxis. They probably can get 100 milligrams of Benadryl. But 25 to 50 IV or IM. Remember, every drug has a risk and a benefit, all right? The benefit for Benadryl and allergic reactions and anaphylaxis is you decrease that histamine response. The risk is, if they're older, you can get some anticholinergic problems. So if you have an older guy with prostate problems and you give him a bunch of Benadryl, he's going to get urinary retention and probably buy a Foley. He's not going to like that. I'm just saying, okay? If you give Benadryl to an infant, to a kid less than 4 or 6 months of age, that Benadryl is an older generation antipsychotic. It will cross the blood-brain barrier, and that kid can become obtunded and lose their airway and quit breathing. So there's a risk and a benefit to every drug we give. What's another big risk to Benadryl? Yeah, yep. I don't think about that one a lot, but that's there. And then what about in the psych patient? What's the risk with Benadryl? Long QT. Yeah, so Benadryl prolongs the QT. So if somebody's already on a bunch of drugs that prolongs the QT and you give them a big slug of IV Benadryl, you can put them in torsades. All right? So that's Benadryl. Remember, the work you guys do is very important. When the cardiologist has his STEMI at the YMCA, he calls you guys, right? You got a big job to do, so make sure you train well. Don't get complacent. It could be my family or your family that needs something. Questions, comments, statements within reason. Remember, for your certificate, you can email Alabama EMS Challenge at Gmail. There's also links should be in the chat box. If there are any comments or questions within reason, let us know. Comments, I like good and bad. You're not going to offend me no matter what you say. If it's useful, we want to keep doing it. If it's not useful, we don't want to waste our time, so let us know. The last few times we've talked about some journal articles. Chief, how do I get out of this? Do you know? There we go. We pull up that journal article. So we've talked about 2 in the past. If you have questions about those, let me know. 1 was pre-hospital use of thrombolytics. I think will be coming to us at some point in the future, not next year, but we're getting there. I've already seen a big increase in appropriate EKG interpretation over the past couple of years. So very excited about that. The other one we talked about was stay and play versus load and go for medical arrest. And we all know that staying and playing is the most appropriate thing. We're taking the hospital, the ER, to the patient with you guys now. Some things, trauma, stroke, time-sensitive things, things you can't manage in the field, things I can't manage in the ER, need to get to the hospital to get the surgeon, the neurologist, or the interventional cardiologist on board. But most things we should manage on scene. This is the article I wanted to put up to share. Is there a way to put that out there for everybody to see too, Chief? To download it or? Okay. Okay. So if you want to look at it, you can. But this is the pre-hospital emergency care. This is the Journal of EMS Physicians, NAEMSP. So it's all geared toward pre-hospital care. This is an article talking about saving lives with tourniquets. Kind of a common sense approach. It's like, duh, you know, if someone has an amputated arm, a tourniquet can stop the bleeding, save the life. But what they did with this article is they looked at about 1,800 cases of homicide in this area, and they looked about at would a tourniquet have made a difference. And the short version is 13% of the homicide in this urban area, had they used a tourniquet, the patient would have survived. That's pretty impressive, 13%. It was only 1,800 victims, so it's a small study, but it goes to say that tourniquets make a big difference. The little things we do make a big difference in life, but you got to use these appropriately, okay? And by tourniquets, I don't mean the blue tourniquet that you put on tight, like you're doing for IV. I'm talking about a tactical combat tourniquet that completely stops the blood supply. Tourniquets, when you put them on, if the patient is not cussing you and they're awake, it's not tight enough. They should not like this, okay? If they're obtunded, they won't say anything. If they're awake, they should be calling you names. But if you don't have access to this, let me know. We can get some articles for you. But this is another good one to look at. And I think we're out of time. We'll take about a 6-7 minute break and then come back and do renal emergencies. And if you're in the Tuscaloosa or around the fire college, we're going to be here from 1 to 3, doing skill stations, mega codes, some airway training, and scenario-based learning. Thank you for smiling. All right. AFC is the password for the test. All lowercase. All right, let's take 5. All right, guys, we'll get started. And again, we're at Alabama Fire College today. I want to thank them for hosting us. And we'll get started. We're going to talk about renal emergencies. If I can find the clicker. The right clicker. That's not it. So we'll talk about the kidneys. You know, the Deep South has a lot of chronic health problems, hypertension, diabetes, and then kidney disease, because it's kind of linked into that. So we see a lot of patients have chronic kidney disease or end-stage renal disease. So we'll talk a little bit about that. Kidneys, they kind of maintain homeostasis or regulation, regulate fluid balance in the body. You know, we think about the kidneys as being a filter of waste, and that is the truth. But it does a whole lot more. A lot of things it does. It manages acid-base balance, blood volume, blood pH. And something it does that a lot of folks don't know is it makes hormones as well. So it also secretes things that help control calcium deposits, and also it secretes stuff like erythropoietin, which helps you make red blood cells. Now, obviously, the bone marrow has something to do with that, but the kidney is a very useful and multifaceted organ. So the way the kidneys work is basic anatomy. They get the blood supply from the aorta. They kind of sit behind the in the retroperitoneal space, so behind the colon, the small bowel. Adrenal gland sits on top of them here. All right. Usually the right kidney is a little bit higher up than the left. This is a little bit off. The kidney has a nephron, which is kind of like a specialized area where it secretes the enzymes and filters the blood. And this consists of a lot of those. So if you look at a gross picture of the kidney, you got the cortex, which is the shell of the kidney. It's very hard and firm, so people in MVCs or blunt trauma, sometimes you'll crack this cortex and get bleeding, and that will rupture. It's not soft and pliable like the spleen or something like that. It's more consistent with like liver texture. Then you got the pyramid here. And this holds numerouses, that's not even a word, is it? Numerouses? I'm from Mississippi, I can say numerouses. Of the nephrons, which consist of the Bowman's capsule, which is like the filtration device. You got the proximal tubule. Anybody know who this is? Don Henley, yes, from a couple of years ago. Very good. You win the prize, yes. You get a certificate today. Good. Don Henley, all right? So with Henley's loop, then you got the distal tubule, and then you got the collecting duct. So. And then through that collecting duct, that comes through here, and it goes into a collection chamber, and then down the ureter, and that is your urine. So that's how the kidneys work. So the kidneys are pretty interesting and a very necessary organ. Each part of this the nephron does something special. So Bowman's capsule filters out the blood, so the blood runs in there, and I think of it almost like an organic strainer. So it makes the first bit of urine, the blood is reabsorbed, and then nutrients are absorbed, reabsorbed, toxins taken out, acid-base balance, everything is done in different parts of these tubules there. That was kind of weird. All right. So when you think about renal issues, renal failure, the first one we'll talk about is acute kidney injury. But there are different causes of acute kidney injury or renal failure. The first one is called pre-renal. So this is anything that affects blood supply to the kidney. So the pre-renal causes of renal issues, the kidney is fine, but there's a lack of blood supply to that. So things that we see a lot of times that cause that is dehydration. The guy that goes out and runs a marathon, at the end of the marathon, he's dehydrated. If I were to check labs on him, it would show that he's got a little bit of a kidney failure. And it's all pre-renal because the kidney is fine, but he's volume depletion. Aggressive use of diuretics would decrease blood supply to the kidneys and make the kidneys get a little bit injured. Sepsis, obviously sepsis would do it because you think about septic shock, hypotension, things like that. Anything that causes decreased blood supply to the kidneys is a pre-renal cause of kidney failure. So the GSW of the liver, all right, that loses 4 or 5 units of blood, is hypotensive for a couple of hours. Post-operatively, we check labs, his kidney is damaged. And we can say, well, that's not good, but hopefully it's pre-renal because of blood loss, and that will kind of get back and get better when we increase the blood supply. There are a lot of intrinsic causes, and by intrinsic causes, I mean things that affect the kidney itself. So pre-renal means the kidney is fine, but getting blood to the kidney has been jacked up, and it's a problem. Intrinsic means the kidney itself has been damaged. So the first thing is like infection. So certain infections can target the kidneys. You can get streptococcal infections that damage the kidney and make even people go into kidney failure and need dialysis because of that. Also, things that infections can do is with the proteins released, the enzymes released by infection, it can cause hypotension. So you get both pre-renal problems and intrinsic problems. So those folks have bad outcomes when you think about their liver kidney damage. Autoimmune, so people with lupus or autoimmune disease or diabetes, the body makes proteins. The kidney makes proteins. The body recognizes that protein as something that's foreign to them by mistake. And so the body, when the blood runs through the kidneys, it thinks that the kidney itself is a foreign body, so it attacks it and damages that. Hypertension and diabetes, those cause massive fluid shifts. So you get diabetic nephropathy. People can't feel their toes or the fingers right. Same thing happens to the kidneys. These vessels stretch, they wax, they wane, damages the nerves. Kidney does not function very well. Obviously, direct trauma can damage the kidneys. So the blunt trauma, penetrating trauma. And then medications. And when I think about, there are a lot of medications that are bad for the kidneys, dangerous for the kidneys. And so when those medicines come through the blood supply and get in this Bowman's capsule here, they filter through and it jacks up that filter, kind of clogs it and breaks it. So things that I think about, a drug that most folks have taken at some point, Bactrim, is an antibiotic. It's pretty bad for your kidneys. So if you have underlying kidney disease, you probably don't need Bactrim. Antibiotics we use in the hospital, vancomycin, that we use for sepsis a lot of times, can dam up the kidneys and cause a lot of problems. So lots of causes for intrinsic reasons. And then post-renal. So post-renal causes of chronic renal issues are things that are something downstream. So blood supply to the kidney is good, kidney itself looks good, but for some reason the urine can't get out and it backs up in the kidneys. Sometimes it even causes those little calyces to rupture and damage the kidney itself. So kidney stones that get lodged in the ureter there can back everything up, all right? Prostate problems in guys, they get an enlarged prostate, they get urine built up in the bladder, that urine builds back up, backflows to the kidneys, parts of the kidney die, so it's post-renal. And then the other time I see this is in patients who have cancer, who get obstructions that block off flow to the ureters. So there's pre-renal, there's intrinsic and post-renal. The intrinsic cause more problems long-term because the kidney itself is damaged. Pre-renal issues, if we can fix the problem early on, the kidney will recover. Same thing with post-renal. If I got a 60-year-old guy with prostate problems who hasn't voted in 3 days and he comes in, his bladder is distended, belly is big, I check his labs, his kidney function is pretty jacked up, I put a Foley in him, as long as that hasn't been going on for a week or so, the odds are his kidney will recover and he'll do fine with that. Labs that I look at in the hospital and the ER to determine we have good kidney function, this is called a basic metabolic profile or a renal panel. I look at the blood urea nitrogen and the creatinine. Those are both indicators of kidney function. So a normal creatinine is 0.7 to 1.3. When you start getting above 1.3, you start realizing that the body cannot excrete creatinine, so the kidney is not working well. So that's a problem. So acute kidney injury, this is a temporary thing. Most of the time it's pre-renal, about 70% of the time. This is the guy we talked about, like the guy running the marathon, or the guy doing the bar hop in downtown Birmingham who drinks beer all night, is dehydrated, wakes up the next morning, he's volume depletion from his alcohol and vomiting. We check a few labs, his creatinine is up. We give him a couple of liters of fluid. The next day, his kidney function is great. Usually it's reversible for the most part. When you think about how they get it, there's community-acquired renal failure or acute kidney injury or hospital-acquired. Community-acquired means they get it before they get to the hospital. That's a lot better because if you're already in the hospital and admitted, we know you're sick, you have underlying health problems. If you get renal disease while in the hospital, it's probably due to the therapy we're giving you, the medications or what's going on with you. It's not as likely to resolve. So we've kind of talked about the pathophysiology of all three of those. The way we diagnose this stuff in the ER is basically by labs, things you can't do in the field. However, there's one test you can do in the field that will determine if somebody's hyperkalemic, and that's an EKG. So EKG is very indicative of renal failure. If you have somebody who says they have known kidney problems, they're oriented but don't feel well, they're weak, you get an EKG and you see hyperkalemia, you know that the kidney problem has progressed to probably moderate or severe disease. Because if you can't clear potassium, it jacks up the cardiac conduction system. Normal urine output for folks is 1 cc per kilo per hour, 30 to 45 per hour for the average adult. Treatment of all these underlying kidney issues that are acute kidney injuries is treat the problem. So the pre-renal stuff, if they're volume down, we give fluids. If it's a traumatic event, we give them blood products, fix that problem. If they're septic, we fix the sepsis, and then we avoid things that jack up the kidney. So if you have pre-renal issues, I want to avoid drugs that damage the kidney because it'd be hard for the body to clear those. Chronic kidney disease is somebody who has dysfunction of the kidney, but it's long-term. It's not pre-renal or anything. It's long-term, usually caused by diabetes or hypertension. Other things that can jack up the kidney long-term use are drugs that a lot of folks use normally. So PPIs, Prilosec, Protonics, those drugs are bad for your kidneys long-term. Probably one of the more dangerous drugs out there, the NSAIDs. So your Motrin, your Aleve, those things you don't want to do every day. You don't want to use them, especially if you're dehydrated. They cause vasoconstriction of the vessels in the kidneys, and that makes the kidney itself not get a good blood supply, bad for your kidneys. We talked about antibiotics already, like Bactrim and vancomycin. Blood pressure medications, so if you're hypertensive, it damages blood supply to all your organs, your brain, your eyes, your kidneys, so we try to lower your blood pressure. But when you lower the blood pressure, it decreases blood supply to the kidney, so therefore you can cause kidney problems. So you're kind of chasing your tail with that. Antihistamines can cause this. A lot of the psych drugs are really bad. These obviously cardiac meds. And then if we take you to the hospital and we're going to squirt you with IV dye for a CT scan, that can mess with your kidneys. So the kidneys are pretty versatile. They can take a lot of damage, but once you get to the point that you have a little bit of underlying intrinsic disease, you got to be very careful about this so it doesn't progress. End-stage renal disease is when the kidneys no longer are able to clear toxins out of your body. You cannot control your electrolytes. You get acidotic, bad stuff. That's what we're talking about now. Problems with end-stage renal disease is basically because of decreased excretion of toxins. So uremia is when you get so much of this protein in your blood that it crosses the blood-brain barrier. These guys get confused, like a liver patient with asterisk. They get confused. They can't walk well. You get nausea, vomiting. Some people get to the point they have comas as well, unable to wake up until you clear that uremia, and you got to do that through dialysis. You also cause fluid shifts. You get dehydration, thirst spacing of fluids. A lot of issues with that. We talked about the erythropoietin. So folks with end-stage renal disease, they get anemic because they grow red blood cells. The calcium problems, they get brittle bones because they can't make calcium as well. Cardiovascular effects. So kidney disease causes chronic hypertension. Anybody seen a dialysis patient with blood pressure like 200 over 120? Yes, no, every day? Yes, 4 times a day? Right, so folks get pretty hypertensive, which causes early cardiac disease, early vision loss, early ischemic disease in the bowel, and it causes worsening kidney disease. Also cause GI problems, so anybody that's got kidney disease, 1, they're anemic, and 2, most of them, if they're on hemodialysis, have to get a blood thinner every day so they don't get blood clots, so they're very high risk for bleeding. They get cerebral atrophy, so their brain kind of shrinks some because of all the bad things going on with them. So if they fall, they're higher risk for subdural hematomas. So chronic disease is pretty bad. The symptoms of end-stage renal disease early on is all related to a lack of the function. So it can be a slow progression, but eventually become altered obtunded because of uremia. They get fluid volume overload, CHF. They get swollen legs. They have no urine output. They get pulmonary edema. All bad things. So when do we start dialysis on people? We use a mnemonic called AEIOU. So if they're acidotic, okay, we need to dialyze them because the body cannot live with a pH less than 7.1 for long. If their potassium is jacked up and too high with EKG changes, we got to fix that. There's some drugs that people overdose on. We can dialyze out and rescue them so they don't die from that. And then volume overload, that's probably the most common one. People just cannot, they're not making urine, fluid builds up in them, they get pulmonary edema, they get weight gain, they get ascites. We got to dialyze that fluid off, take it off. And then we talked about uremia. We talked about confusion. Uremia also will cause pericarditis, which can lead you to pericardial tamponade. So a lot of madness with the kidneys. You want to keep your kidneys functioning. There are 2 types of dialysis. There's hemodialysis and peritoneal dialysis. Hemodialysis is probably the most common. I know the non-fire-based guys do a lot of transports to and from dialysis units. Peritoneal dialysis is usually done at home. Gives folks a little bit more freedom. You're not stuck in a chair for 4 hours a day, 3 days a week. With hemodialysis, we put a big IV in you. It's got 2 big ports, sometimes 3. So we pull blood out, run it through a filter, corrects everything, and then push it back in. There are types of catheters, and I say this because the way you manage these, if they malfunction or come out, is a little bit different. There's non-tunneled and tunneled catheters. So a non-tunneled looks just like a central line you might see on somebody in the ICU or in the ER. Basically what I do here is I take a needle, I put the needle in the vein, all right, I aspirate blood back, I put a wire in there, and then once the wire's in there, I make a bigger incision in the skin, and I put this big freaking IV catheter in there. Okay, it's about so long, it's got 2 to 3 lumens, and it sits over the top. So it's direct contact skin in the vessel. If this were to come out and start bleeding, because remember they're going to be on blood thinners already, direct pressure usually works. Stops the bleeding, not a big deal. If they're in cardiac arrest and you have this access and no other IV access, this is the usable access. This is not some magic line you can touch. Okay, cardiac arrest, you can use it. If they're not in cardiac arrest, you don't want to use it because we want to try to save it for dialysis. But IVs hook up, you can flush, give medicines, IV just like you would anything else. The point, if it comes out, direct pressure usually stops it, makes it better. This is a tunnel catheter, it's different. So basically, I do the same thing. I stick the vessel, run my wire in, make an incision, put the catheter in, but the catheter is two parts. So they hook up right here. So the line goes in, I got a wire. I put my catheter in, and it's two parts. So my catheter goes in, and then I take this end of it, and I tunnel it under the skin, and bring it back out. So I got a long piece of that catheter under the skin. And the purpose for that is for long-term use. So now there's a less risk for infection for these people, all right? So that's good for the patient. But the problem is, if this were to tear off or kink right there or right here, you still got all this space of a big freaking hose under the skin. So this is going to pump and pour blood out. So it's a little bit harder to manage. So this may take a knee on the chest or direct pressure with the thumb or a lot of pressure to control that because you got a hose under the skin, all right? So these are more significant to take care of if they start bleeding, all right? And a lot of times if these get snatched on something and get pulled, they'll come apart right there. That can cause significant bleeding under the skin that comes out the end of that tube. So it takes a lot of direct pressure to manage that. So a little bit scarier. So that's tunnel. But again, in a code situation, you can access those. Last protocol update even talked about, gave you an algorithm or a pathway to unhook these, tape them up, to transport patients. That's fine. Obviously, don't use the IV access here unless the patient's in cardiac arrest. Because most folks on dialysis, if you think about it, if you kept this vessel, this catheter in this vessel for 2 years, it's going to get all scarred up. So if this gets infected or broke and it comes out, we can't use this site. So now I'll go over here, give that a couple of years, same thing happens, then put one in the groin, do the other groin. Eventually, there's no place to put an IV in these people, and they die. So be very careful. But again, cardiac arrest, you can't get access. If you can't drill them, that's a reasonable thing to do. So the flush volume is probably the same. So the catheter is about the same length. So I'll do 5 to 10 cc's. I think most places use heparin for that. If you don't have heparin, saline is fine. When you get to the hospital, we can put the heparin in there. And again, when people get dialysis, they always get a big dose of heparin. So these things usually do not clot off for the most part. All right, that's working from there, Chief. All right. So long-term use, other things we can do fistulas or graft. A fistula is where we go in and we make an incision at the vein and an artery, and we sew them together. And then 3 or 4 months later, that thing eventually grows, and it gives us a big access so we can put a big bore catheter in to do dialysis. But that's a fistula. We can also do loop grafts, work the same way. We go in there, put one end in the vein, one end in the artery, and now what we can do is for dialysis, I take 2 needles and I hook it up, and we do dialysis that way. These don't take too long to mature. That fistula sometimes takes months for this thing, because what will happen is we sew those together, and then this grows really wide. And you can see, like on this picture here, this is a loop graft. So this is long term. You can feel these. You should feel what they call a thrill. You feel the fluid going through there. The volume is high flow. Makes it easiest to get access and do dialysis on these people. Complications during dialysis, you get hypotension because you think about they're normally hypertensive, and then you start pulling volume off. It drops the pressure. They get hypotension. They get hypertension. A lot of times we give people medicines, an oral vasopressor to take, Midodrine. They take that before dialysis so they don't get too hypotensive. Disequilibrium usually happens the first 6 months to a year of dialysis till your body gets used to it. So basically you think about it, when you go for dialysis, if you go Monday, Wednesday, Friday, so On Monday, you've had 2 days of toxins build up in your blood. Your body's used to it. Your potassium's probably a little bit high. You're a little bit acidotic. And then when you take all that stuff off, it's like a refreshing of the body, and you feel weird. So there's a lot of issues with that. So that's disequilibrium. Obviously, if they don't flush the lines before they dialyze somebody, you get a big air embolism, and that's a lot of air, not a good thing. Electrolyte abnormalities, obviously, potassium is the big issue, and also volume overload. So it takes a few months to figure out how much volume to pull off these people so they don't get hypotensive or have issues. They get low blood sugar because we're kind of filtering out their sugar as well. So a lot of times these guys will eat or drink during dialysis as well. Questions you want to ask folks on dialysis when you see them: what days do you go? Are you a Monday, Wednesday, Friday player, or Tuesday, Thursday, Saturday? And that would give you an idea how long they missed dialysis if they have missed it. What is your dry weight? They all should know that answer. So if they normally weigh 100 pounds, okay, that's not going to happen in Alabama. Normally they weigh 200 pounds, and you pick them up and say, I weigh 260. You know they got 60 pounds of volume on them. So they're probably going to be volume overloaded. They probably need to do sit-up, probably need BiPAP, things like that. And what vascular access is functioning. So a lot of times people will have an access in their arm or leg, and that's either not matured or it's clotted off and they've left it in there. They may have a big catheter in their chest or something as well. So those are things you want to ask them to kind of know what's going on. And the other important thing is, do you make urine? And remember, the body, the kidneys filter out the urine, but the kidney also secretes enzymes and hormones. So if they make any urine whatsoever, we still don't want to give them drugs that are bad for the kidneys because we can kill that kidney off even more. If they make no urine, the kidneys are completely gone, it doesn't matter. I can give them any antibiotic, I can get them contrast, do all those things, and we dialyze it off. But if the kidney functions even a little bit, we want to save that function so that they don't have big issues with hormone regulation. Questions or comments? Anybody still awake? Oh, a question. Praise God. This is good. Yeah. All right. So when they get into rhabdo is you get breakdown of skeletal muscle cells, and that muscle breakdown releases a protein. That protein gets in the blood, and it gets stuck in that Bowman's capsule. So like that picture of that filter I showed, the air filter that was full and broke, same thing. Those big proteins go through that Bowman's capsule and tear up the filter. So it causes kidney problems with that. It's just a big bad protein. Correct. Can cause, yes, yeah, right. And that's why certain drugs can do it too. So some drugs cause vasoconstriction of the vessels in the kidneys, which causes kidney problems. Some drugs are big and damage Bowman's capsule, and then some drugs get through that capsule but jack up the tubules as well. So it just depends. Tubules. Is that even a word? Tubules? Okay, all right, tubules. I just made it. So complications of vascular access, things to think about. So this is a graft here. You can see there's a Band-Aid over where one poke is. Then you got this spot right here. So you can get erosions from repeated punctures. You think about this as Gore-Tex graft. After a couple of years of being poked and prodded, that would give way, all right? You can also get infections around the graft and abscesses, and those chemicals from that abscess can tear up that graft as well. All right? You can get aneurysms, and that's where the graft kind of breaks apart, and it splits in half, and you get fluid in there. Same thing, you can have aneurysms around some of those fistulas as well. There's a weakness in the blood vessel wall. So bleeding from this is rare, but can be life-threatening. Just imagine, you got a big plastic tube tied to an artery and a vein, and if this were to rupture, big bad problems. So direct pressure would be the first thing you want to do. All right, combat gauze maybe, but the odds are if you got a piece of plastic attached to your artery and vein, you need a tourniquet on these people. So even if it's minor bleeding, I'm going to put my tourniquet high and tight above that and have it there in case I need it. I may not crank it down and this it starts spurting. But if you ever see one of these leak, it's pretty scary. It's like a massive injury. They need rapid transport to a trauma center. So you need a vascular surgeon or a trauma surgeon, somebody can clamp off that vessel. You really want a vascular guy so they can fix it and we can use it again for dialysis. But if not, the trauma guys can stop the bleeding and keep them from dying. So this is... No, so this access site. So this is bleeding. They want you to leave it alone, except maybe a 4x4, because they don't want to mess it up. That's what we're taught. This is the lifeline for these folks on dialysis with end-stage renal disease. However, if that thing is pumping blood like a fountain, you got to stop it or somebody dies. And if they give you crap about it, let me know. So again, this is very concerning. This makes me uncomfortable. See this on one of your patients, and they would say, should I go to the hospital? The answer is yes, because what I'm going to do for this patient is I'm going to get an ultrasound. I'm going to look to make sure that graft is still patent and it's not about to rupture. Different pictures, some aneurysms. This is a guy that got a tattoo on his of a snake. That's pretty cool. You know you're tough. Peritoneal dialysis, basically we put a catheter into the peritoneal cavity, and then at night they put fluid in, and that fluid circulates through here. It pulls the toxin out of the gut and out of the acidic fluid they have. In the morning they throw the bag back on the ground, it all drains out, and that's their kidney function. These guys are usually do it at night, so they're more functioning in the day. They're not stuck somewhere a couple hours a day doing dialysis. The biggest risk for this is peritonitis. And if you get an infection inside your belly, it's very bad. You can become septic and die from that pretty quick. So they're pretty aggressive about keeping that site clean. I'm sure y'all seen that video. It makes me squirm. That's right. That's right. Somebody's on leave with no pay for a while. So this is 56-year-old male, end-stage renal disease, dialyzed 4 days ago. He got a paycheck, had to smoke some coke. They picked up at a local hotel. Complaints of shortness of breath. Heart rate's in the 50s. Respiration is 32. And just like last time, if I'm counting more than 4 or 5 respirations in that first 15 seconds, I'm done. I'm looking at. All right, sorry about the audio issues, guys. So back to earlier, when you think about CHF versus fluid volume overload with end-stage renal disease, you know, position pressure is the most important thing. You sit them upright, CPAP or BiPAP. They need nitro, which decreases preload, decreases the amount of blood return to the heart, dilates them out, increases the bit of the heart to pump that fluid out of the lungs. Obviously, need oxygen, okay? Morphine is great because it causes a histamine release, lowers the blood pressure. Lasix, probably not very useful in dialysis patients. If they're a heart failure patient, you want to hit them with Lasix in the field, that's reasonable. I don't do a lot of Lasix even in the ER for CHF now. It's more of an inpatient kind of thing. Most people volume overloaded or volume overloaded in the wrong place. So if you can get the fluid out of the lungs, you're doing fine. You don't have to diurese them. So looking back at this picture I showed earlier, this is very concerning. There's just something under the surface. You don't know what's going on. If this ruptures, it's a bad outcome for this patient. Massive blood loss. A lot of scary things can happen there. So this was a patient that was about a block from the place I was working. Dialysis patient, they have a graft in their leg. So this is the groin. Head's going up here to the right. Legs, feet are down to your left. Got a loop graft here. If you have a graft in your leg, that's a sign you've been on dialysis a long time, and we don't have access in your arms or your chest or your neck anymore. So it's a sign of a chronic dialysis patient, probably has multiple comorbid health problems. So this patient was at a gas station about a block away from the place I was working and had a scab that looked sort of like the other one on that leg. That thing popped and blood was pouring out. EMS was just around the corner. They showed up. They were able to get a tourniquet on the leg and crank it up pretty tight and bring her into me. When I saw her, it was probably about 18 minutes since everything started. She was probably half a tank out of blood cells. So she was pale. She was altered, could not get a blood pressure. She was talking to you, so you know she had a pulse, right? But couldn't palpate a pulse. So we cranked that tourniquet even tighter, control the bleeding. Initially, we put combat gauze and packed that because it takes a lot of direct pressure. Had this loop graft been any higher up in the thigh, we probably couldn't have stopped her bleeding and she would have died, okay? So the way you manage this is aggressive hemorrhage control. She was probably half a tank down. So at that point, we start massive transfusion as well. So she got FFP. She gets TXA. TXA is category A for hemorrhagic shock in our state. It's 2 grams over 20 minutes. If you only got 1 gram, so be it, use it. Remember the folks that get dialysis, they get heparin boluses every time they dialyze, so the blood's always a little bit thin. But basic stuff saved this person's life. So the EMT on scene, throwing a tourniquet on there, cranking it up, slows the blood down. It took a pretty good crank to stop it completely. But tourniquet use, TXA, got blood products. We also gave her FFP, which is clotting factors, to fix that. And then we got a choice. We either call a vascular surgeon or a trauma surgeon. A trauma surgeon can fix it, but then you're not going to dialyze it. So hopefully you get a vascular surgeon, or if you work at an academic place, you can get one of the renal transplant guys who can work on these as well, and they manage this. But this is somebody that could very easily have bled out and died, and it'd been kind of a waste that someone dies from something that we can fix. The other issue with this patient was what? IV access. So if they got this access in their groin here, you know it's tough. So she bought a couple of IOs as well for rapid fluid administration. We can cheat in the hospital and use an ultrasound and put a central line in them. But again, the problem is if she's got a graft in her leg, her neck's probably scarred up and her chest is scarred up, and it's going to be tough to get this in there. Very scary, but calm head and a tourniquet goes a long way. You can see the erosion on that picture to the right. Got to be fixed. It's over time, right. So they're going to have a scab or a little sore there. They're going to pick at and look at it, and it's going to be fine. And then 6-8 weeks later, that thing's just going to pop. So anybody that's got a sore on their access graft that you're taking care of, the recommendation is go to the hospital. We get an ultrasound, and that will tell us the stability or viability of that graft. Cool. Questions, comments, statements within reason? I'm not sure of that. I'm not. What I will tell you, though, is but the question was, is there a reason that end-stage renal patients that go into cardiac arrest stay in persistent VFib? Don't know the answer to that one. But I will tell you, end-stage renal patients are high risk for hyperkalemia. So if you run in a call with somebody that's got an access graft or you go to a dialysis and they're in cardiac arrest, they get calcium. No ifs, ands, or buts, right? Because if they're hyperkalemic and they go into the problem with hyperkalemia is when that QRS gets wide, little things can make them go into VTAC or VFib. So a bump on the road, little vagal maneuvers. If they're in the hospital, if I'm doing an OG tube or even intubating them, they go into VTAC or VFib. And what's the current treatment for VTAC or VFib? What do we do for those guys? Doc, CPR, and what drugs do we give? Amiodarone, epinephrine. Does that fix hyperkalemia? It does not. So folks that you think have renal disease that go into cardiac arrest, they get calcium because that's the only way that you can fix them, right? So if they're in VFib from hyperkalemia and you shock them and give amio, you're not going to get them back. You got to go with the calcium at that point. Yes, sir. I'll give it right off the bat. Yep. So if I show up on scene at a dialysis center, the nurse is doing CPR. Okay, we're going to get around. I'm going to start picture with CPR. Somebody's going to drill. The first drug I'm going to give is calcium, as I'm getting them on the defib pads and everything else. Because calcium, if they're in hyperkalemic, you're going to fix them or help fix them. If they're not hyperkalemic, you're not going to hurt them. There's no risk, but there's a potential benefit, right? So every code's a little bit different versus the 40-year-old male that's having chest pain. As soon as you get there, the first thing you can do is you're going to shock that guy, right? So a little bit different, each code. Yes, sir. Sodium bicarb may help correct the acidosis and will lower the potassium some, but calcium should be given first because calcium is going to protect the heart. Yeah. Does anybody carry more than 1 amp of calcium in your ALS box? No. You got 2? Yeah. So if I was running a code on dialysis patient, I gave 1 amp. I'm doing the picture CPR. I got IO access. I look at the monitor. It's PEA or it's VFib or whatever. I start that algorithm. Okay. After I give that first drug, I'm gonna go back and give that 2nd amp of calcium as well. Sometimes it takes a couple to do that. Other questions, comments within reason? Any jokes within reason? Mine will get me in trouble. All right, I'd like to thank the Fire College for sponsoring us, bringing us out here. Thank you so much, sir. I appreciate this. You know, the goal of EMS Challenge is to give you physician-led Con Ed. This should not be everything that you get for your Con Ed. It's not the end-all, be-all. It should be a part of that. That being said, every agency needs an active medical director that is a practicing ER physician. Medicine is changing so fast. The things that were in the textbooks 2 years ago. We have protocols now. You guys are doing ketamine, you're doing push-dose epi. EMTs are doing BiPAP and devices. EMS is moving forward. And you guys are got to have an active medical director, okay? YouTube channel, watch us. We got free college. We're gonna do and Pit Crew CPR. We will be in Alabaster, right? Alabaster, I got it right that time. In December, we'll be in Anniston, and then we'll be in Foley in January, and then still one day a month we'll be at Point. If you have questions or comments within reason, reach out to us. Feedback, good or bad, we need it. Doing it. If it's not, I want to change it. And see you at 1 o'clock. Thank you.